Telling Addiction. I'm Dr. Susan Blank. You're listening to America's Web Radio. Today in studio with me, I have Michael Daly and David Donaldson from the Atlanta Healing Center. Hi, guys.
Hello. Hey, thank you.
Are you enjoying the pollen? I know I am. So if my voice gives out, you guys are going to have to be the ones that carry the show. Interesting topic today. But before we get into that, I would just like to remind everyone that the DEA Take Back Day is actually a week from Saturday on April 26th. Please go to DEA.org or Google DEA Take Back Day, and you'll be able to find the areas in your area, the places in your area that are going to be providing safe disposal of all of your old medications. So as you're doing your spring cleaning, as you're looking at your cabinets and your medicine cabinet and wherever else you have old medicines, whether it's prescription or over the counter, really important to clean those out, because we do know, and we've talked about this over and over again, that the primary source for the initiation of substance use, particularly the opioids, which is going to be our topic today, is not from the drug dealer. It's not from the pill mill. It is from the patient's family members, relatives, friends, neighbors. Medicine
From China, it's coming from China, it's coming from China. And of course, they've always denied that. But now, fortunately, in the news, they're saying they're going to make all forms of fentanyl a controlled substance so that they can help stem the tide of that drug coming into our system. And hopefully it will.
So, yes, apparently President Xi Jinping followed up.
Very good.
I have a nice Chinese tutor. Shout out to Lou, who works at the Atlanta Healing Center. But Dr. She did, she did promise President Trump at a meeting in Barbados that he would do what he could and take some action to see if this flow of fentanyl that was coming out of China could be stemmed. Now, a lot of folks are aware that what's happening is that fentanyl is being manufactured in China, sent usually to Mexico. But I have to tell you, in contact with our Canadian colleagues, there's a lot that's coming in through Vancouver as well. And that they're seeing a large number of fentanyl deaths, overdoses, and problems there in Vancouver. So that's the other way that it seems to be coming in, but coming in through Mexico.
And it's my understanding that certain fentanyl is graded as research, or what's the other word? It's not a prescription drug. It's designed industrial and used as a chemical for other things. So it's not even controlled at that point.
Right. And that is one of the difficulties, and one of the things that they were seeing, particularly in Vancouver, wasn't necessarily that the fentanyl itself was coming, but the ingredients were coming. And that some of the drug dealers there had actually been able to get pill presses to form pills, and the dye, the actual color of OxyContin. So they would have a pill press to make these tablets that looked exactly like OxyContin, exactly like the OxyContin 80 milligrams. And it was the same color, it was the same pill press, and this was one of the ways that the pills were being distributed in Canada, but also in the northwestern part of the United States. So they are very clever, and that's one of the problems if President Xi does decrease or eliminate the actual fentanyl coming out of China. These raw ingredients that Apparently the recipe is not that complicated. Once you have the raw ingredients, they're able to manufacture it fairly easily. And because the amounts that you need to have
an effect.
an effect. I was going to say effective dose, and then I thought, I don't really want to say that.
See, I thought you were going to say the amounts you need to sell in order to become a millionaire, because $1,000 worth of the ingredients will bring them back over $1 million worth of return. So it's
lucrative.
It's lucrative.
Very high push to do that.
It's a smaller amount than you need for heroin or other drugs.
Well, and it makes it much easier to transport.
Correct.
And the other part, similar to when Georgia was trying to deal with spice, and they kept passing laws that the manufacturers of spice would just change the ingredient by one molecule and it would be legal again. China is doing the same thing, where the makers of fentanyl just keep changing the ingredient slightly and it becomes illegal. So now China is making all forms of fentanyl a controlled substance.
And all of the analogs. And that therein lies the other problem. And one of the reasons that I think we're always behind the curve and not necessarily aware of all of the deaths that are related to fentanyl is that these analogs have the same effect. Some are more potent, some slightly less, but they are very difficult now to detect on drug testing.
Exactly.
So our drug testing companies are scrambling to try and make sure that they've got the right substrates to be able to detect the
metabolite,
the different types of fentanyl.
I was actually looking at our drug screen reports the other day, and it used to be, you would look at it and maybe 2 computer pages to get all of the different substances that are being tested for.
Right.
And now you look at it and you see the classics: marijuana, alcohol, cocaine, benzos, and then you see synthetic cannabinoid, synthetic opioid, just 3 pages of these things they're having to throw in to do these tests.
Well, and that adds to the cost.
It adds to the cost
because they have to recoup that research that they need to do to keep up with these drugs, even though they're behind.
Right.
They're behind, but they still have to stay, 1 step instead of 5 steps behind.
Correct. We're going to take a break. When we come back, we'll continue with this update on the opioid epidemic. Thanks for listening.
The disease of addiction is a life-altering challenge, not just for the person suffering its effects, but also for the family and friends who support and love the one caught in its grasp. What should be the course of treatment? Who is the best person to render treatment? And what is the best place to go for the care that is needed? We know that you want answers to these and many more questions. Call 770-696-9862 and speak to a representative of the Atlanta Healing Center. They can tailor a program specifically designed to address the needs of the person suffering with an addiction, or give you guidance as to where that help may be found. Information is the key, and the trained staff at AHC is here to assist. If you wish, you can also get more information on the website located at www.atlantahealingcenter.com.
This is Dr. Susan Blank, host of Detailing Addiction on America's Web Radio. Please join us at 4 p.m. on Tuesday afternoons.
Perhaps you are struggling to cope with the disease of addiction. If not, you probably know a family member or friend that needs help in battling the cravings and the personal and professional damage done by the effects of drugs or alcohol. Get a pen and paper and be ready to write down the following. These are the issues that the trained staff at the Atlanta Healing Center address and treat every day. Their doctors and counselors with over 40 years of practice in the field of addiction can treat the suffering individual in a thoughtful, compassionate, and experienced manner and guide him or her along the path to recovery. So call 770-696-9862 and speak to a knowledgeable staff member about how you or your loved one can be helped to enjoy a better and healthier life. More information is also available on the website at www.atlantahealingcenter.com.
You're listening to America's Web Radio on the AmericasBroadcastNetwork.com. Thank you for listening.
Welcome back. This is Detailing Addiction. You're listening to America's Web Radio, and I'm Dr. Susan Blank. Today in studio, I have with me David Donaldson and Michael Daly from the Atlanta Healing Center, and we're talking about the opioid epidemic and some of the recent updates. So this past week, the CDC came out with some clarifications of their famous guidelines that they put forth, recommendations for prescribing opioids for chronic pain and also acute pain. These guidelines were developed and directed towards primary care doctors who were often prescribing opioids for the first time for acute pain or chronically. One of the problems with the guidelines was that the insurance companies were looking at the guidelines and applying them across the board to all opioid prescriptions. So they were wanting every patient to be on less than 100 morphine equivalents every day. They were wanting to not have more than a 7-day supply, and they were not allowing the doctors or the patients to refill more than 7 days of these medications. Now, that has created all sorts of havoc at the drugstores, for patients, for doctors' offices, because as you may know, these prescriptions have to be written out and signed. You can't give any refills. You can't give more than the guidelines because the insurance companies were refusing to pay for them. So the CDC came out and clarified that this was not meant to be anything other than a recommendation that prescribers think about what are the alternatives, what are some of the cautions that they might want to take, and that they were not meant to limit or to dictate prescribing. That patients, particularly those with chronic ongoing pain, for those with cancer pain, sickle cell disease, other painful chronic conditions, they did not mean to restrict or limit the ability of patients to be able to get treatment. And this letter from the CDC was requested by the American Society of Clinical Oncology, the American Society of Hematology, and then National Comprehensive National Comprehensive Cancer Network. So they were asking, please come out and clarify this. And so last week they came out with this information. The CDC encourages physicians to continue to use their clinical judgment and base treatment on what they know about their patients, including their use of opioids, to determine what is the best course of treatment.
Well, it's the same old thing where we go to one extreme and then bring it all the way back to the complete opposite. And we can't have that. We need to look at some middle ground. And
it's nice that the CDC is affirming the patient-doctor relationship, because that is where the final decisions have to be made. That's where the consequences lie if something happens. And to be letting the insurance companies know that it's the doctor that calls the shots. It leaves me questioning how much clout the insurance companies listen to the recommendations that come from the CDC, or how long
well,
the backlog
listened in the beginning.
They'll certainly listen when it says they can restrict.
Tighten those down very quickly. And there were pharmacy chains, national pharmacy chains, that were not going to honor more than a week's supply of medications. There was a lot.
And one thing that people don't think about that happens at centers like ours is doctors start cutting off patients because they've been overprescribed, or they've gotten tolerance to the point where this doctor can no longer safely prescribed. So they cut them off, and then they call places like us, and they're wanting relief, but we can't give it to them.
Because they're suddenly in a state of withdrawal, and their supply is turned off, and we're not able to just automatically step right in and fill that gap.
No,
they've got some major life changes to survive.
Right.
And I get calls all the time from people that are saying, well, I've been cut off. I only have 3 more pills. What do I do? I can't get into another doctor for a month. There's nowhere to go. And these people are, like you said, are going through withdrawal.
But and real often these people have legitimate chronic pain
Right.
issues, or they have pain issues that have been created by the opiates that have to be managed, or else you're really putting somebody at risk. And so you have to allow the decisions to be with the physician.
And that is where a lot of the doctors are getting so frustrated because of the situation where if they have to write a new prescription every week for the patient, then they have to do a doctor-doctor review with the insurance company to cover the medication. They have to talk the pharmacy into filling the prescription. They have to explain delays and so forth to the patients. They have to institute some drug testing that they might not have done before. The hassle factor gets greater and greater, and the physician and their staff cannot manage this huge increase in paperwork, time, and hassle that they're taking some action out of their own frustration or the lack of understanding about how to taper it, that the FDA last week actually came out with a statement about the harm of sudden discontinuation of opioid pain medication, and wants the labeling and the guidelines to be changed to allow the doctors to individualize tapering if that is appropriate. Because that, Michael, just as you said, David, just as you said, what was happening is the doctors were getting frustrated, feeling scared, getting nasty grams from the insurance companies, from the pharmacies, from the and then a lot of complaints from the patients. And so they're just saying, I can't do this anymore. So the FDA said, okay, we can't suddenly discontinue. That is not the correct way to do this. There are ways in which we need to talk about individualizing and the taper of the medication. If it is appropriate for the patient to be on a lower dose, and sometimes patients can be managed on a bit of a lower dose. Mm-hmm. And so the way to do that, though, is not to cut the dose in half or to tell the patient, here's a month's supply and I'm done and we're not going to do this anymore. That is not how this needs to work, because there's going to be a lot of suffering. Not everybody on pain medicine, the vast majority of people on pain medications do not have the disease of addiction. They are not misusing their medications. They're not running out early. They're not taking more than they're supposed to. They're showing up for their doctor's appointments. They're being compliant. And so
But even the ones that are compliant, they cannot stop just cold turkey.
Right.
Or a half. I'll take half today, half again the next day, and down, and think I'll be done in 4 days. That's not how it works.
Right. And the patients are either going to suffer, they're going to seek out other ways to get the medication, maybe go to a different doctor, show up in an emergency room, borrow from their neighbor and friend. They may even resort, as we've seen patients do, to heroin. Some of these folks do have addiction, and that's where the disease has taken them. But some of them are just caught in the crossfire of the CDC guidelines, the insurers ratcheting down, and doctors not really being trained in the proper tapering of these medications.
Well, and at the same time, there's been kind of a fear for doctors and prescribers from the DEA,
Right.
that they're going to show up and knock on the door and want to see their prescribing records and potentially take their licenses, which has, I mean, there's been legitimate reason for the DEA to come knocking on the door, but it also has created a fear amongst a lot of prescribers. And so it's not been an unheard of practice for them, if a patient runs out early by a day or two, for them to just cut that patient off and for them to then turn to the street initially for opiates, but it always goes to heroin eventually, because the street price for regular opiates is
So high.
astronomical.
So high. And the FDA has received a number of serious complaints and reports of serious harm. Now, people aren't going to die necessarily from opiate withdrawal. It is not going to kill you in the way that you might die if you're coming off benzodiazepines or alcohol. But there have been a number of reported suicides for people that have been in opiate withdrawal. It is horrible. I wouldn't wish it on my worst enemy. And many people do not know how to tolerate it, do not know what to do. They're confused, they're scared, and some of them become
Very
seriously
sick.
Psychologically distressed and have committed suicide. So the FDA felt like that they needed to come out with this statement about do not suddenly discontinue or rapidly withdraw the medication from these patients. It is not okay. We're going to take a break. When we come back, we'll talk more about the opioid epidemic. Thanks for listening.
Perhaps you are struggling to cope with the disease of addiction. If not, you probably know a family member or friend that needs help in battling the cravings and the personal and professional damage done by the effects of drugs or alcohol. Get a pen and paper and be ready to write down the following. These are the issues that the trained staff at the Atlanta Healing Center address and treat every day. Their doctors and counselors with over 40 years of practice in the field of addiction can treat the suffering individual in a thoughtful, compassionate, and experienced manner and guide him or her along the path to recovery. So call 770-696-9862 and speak to a knowledgeable staff member about how you or your loved one can be helped to enjoy a better and healthier life. More information is also available on the website at www.atlantahealingcenter.com.
Hi, I'm Dr. Mike Karuchak. Join me and my co-host, Dr. Hal Schertz, every Thursday morning at 8 a.m. and listen to the Doctor's Lounge, where you get a private insight into the conversations that doctors have amongst themselves. Join us Thursday, 8 a.m. every week.
The disease of addiction is a life-altering challenge, not just for the person suffering its effects, but also for the family and friends who support and love the one caught in its grasp. What should be the course of treatment? Who is the best person to render treatment? And what is the best place to go for the care that is needed? We know that you want answers to these and many more questions. Call 770-696-9862 and speak to a representative of the Atlanta Healing Center. They can tailor a program specifically designed to address the needs of the person suffering with an addiction, or give you guidance as to where that help may be found. Information is the key, and the trained staff at AHC is here to assist. If you wish, you can also get more information on the website located at www.atlantahealingcenter.com.
You're listening to America's Web Radio on the AmericasBroadcastNetwork.com. Thank you for listening.
Welcome back. This is Detailing Addiction. I'm Dr. Susan Blank. You're listening to America's Web Radio. I have with me David Donaldson and Michael Daly from the Atlanta Healing Center, and we're doing an update on the opioid epidemic because there have been a number of changes over the last couple of weeks, clarifying for physicians in particular, for prescribers and other healthcare practitioners, some understanding about the original CDC guidelines, as well as the dangers in stopping the medications suddenly.
There's been a couple of syndromes. I don't think they've officially reached the level of disease yet, but there's been a couple of syndromes that we've seen when people have been suddenly stopped from opiates. One is a depressive syndrome,
Right.
where the opiates appear to have been actually managing the depression, and now they can't really deal with the emotional pain. And the other is chronic all over pain that tends that I'm not sure of the name of it, but it's a pain that they're experiencing. You keep thinking that, okay, your natural pain system is going to kick in eventually. You're off the opiates for a while, and eventually your endorphins and things are going to kick back in, but they don't.
Right.
And there are patients that are left in this state of physical pain, and they're unable to get medication.
And this is something that we weren't as aware of before this sudden change in how doctors can prescribe or perceive that they can prescribe opioids. So one of the things that we know for anybody going through opioid withdrawal, people who don't have any pain problems at all. They have no injury. They don't have sickle cell. They don't have cancer. They weren't taking the opioids because they had a chronic pain condition. They were using heroin or other opioids. When they're going through withdrawal, one of the classic symptoms is back pain or body pain, joint pain. They hurt all over. And that is an actual function of the withdrawal of the medication. So when you add that on top of whatever chronic pain is being treated, it can be excruciating. The other thing is that if somebody has been on an opioid for a long period of time, just like we see with testosterone, for example, if somebody takes testosterone for a long period of time and then they stop it, their body doesn't come back online and make testosterone. That system has been shut down. If people have been on thyroid medication for a while and then for whatever reason stop it, their thyroid doesn't magically come back online and start working. The same thing happens with the endorphins and the enkephalins, the indwelling pain relievers that we have in our brain, where their action is on the opioid receptors. That's why we have opioid receptors, and that's why we have these natural opioid to help us in acute pain situations, to be able to have enough time to get ourselves to safety, and to help us. And some people may have very well had the experience of you cut yourself and you look down at your finger and you don't really feel it initially. You can see the blood start to percolate. You can maybe see the bone and you think that's really going to hurt. But you have enough time because of the natural endorphins to actually put your finger around it, stop the bleeding, get a paper towel, put it under the water, whatever you need to do, and then it starts. It's
usually right when you put it under the water.
Yeah.
That the stinging really starts.
That the stinging really starts. But that's a natural system to help us. People have been wounded in battle, but have been able to get themselves or one of their fellow soldiers to safety, not even recognizing that they themselves have been hurt. So this system is there. That's why we have the opioid receptors. But when you've been taking opioids chronically, that system shuts down. Right. So you don't have the natural pain relief. And we know that for many people, there is emotional pain as well as physical pain. When somebody has an injury, maybe they've now lost their job because of a catastrophic injury. Maybe they're dealing with cancer and there's the pain from the cancer, but there's the emotional pain of going through chemo and the effects on their family and all of that. So there's this depression that also develops. It's very, very interesting to see these syndromes that are starting to be revealed as people are suddenly taken off their opioids.
Mm-hmm.
And
we see it a lot.
And the pain associated acutely with withdrawal, and then the indwelling pain relief is just not there anymore.
Mm-hmm.
And they're left with a depression that is not responding to antidepressant
Correct.
medications. They're just having to kind of live through this and begin to hope that they're going to be able to start experiencing other feelings eventually.
It's really quite tragic.
So part of what's also been talked about is that medicated assistance for recovery. I believe in the same article from the FDA that medicated assisted recovery is very, very important. Part of the concern for me when I hear that is so many places only think of either methadone or naloxone. They jump from one or the other. Either they're going to the methadone clinic and their life is now going to be forever at the methadone clinic, tethered, or they're going to be on this naloxone and it's going to block everything from their system
but not treat their pain.
And they're going to be left with all this pain and left with this inability to experience any joy. So I think that it's really crucial that people remember buprenorphine is also a very, very effective medication for medicated assisted recovery that treats both the emotional and physical pain.
And in fact, there have been studies, I think they've gotten derailed recently, if I'm recalling correctly, of an antidepressant that actually uses buprenorphine because of its action on the kappa receptors. We have 3 different kinds of opioid receptors. We have the mu receptors, that's pain relief, and that also has some of the side effects that people are familiar with when they take opioids, like being constipated or itching or other kinds of problems. We have the delta receptors that we don't know too much about, and then we have the kappa receptors, and it's the kappa receptors that are responsible for overdose. So that's the part of the brain that is actually stopping the person from breathing or remembering to breathe. And the kappa receptors create a feeling of dysphoria, an uncomfortableness. So when there's action on the kappa, people feel depressed, irritable, uncomfortable. They have dis-ease, so to speak. Buprenorphine is active at the mu receptor, but it's an antagonist at the kappa, so it blocks the kappa. That's why medications like Suboxone, Sublocade, which is the injectable one now, these block at kappa, so it's very difficult unless you've added other drugs on top to overdose, because they are an antagonist. They block the kappa receptors, and they block that dysphoric mood, that depressed mood. And so there was a medication that was being tested for it as a unique antidepressant. That was buprenorphine plus another full kappa antagonist. The FDA approved ketamine that week as a novel antidepressant, but they did not approve the buprenorphine because of the potential risks. So back to the drawing board, but many of us who work in this field have known for a long time that there is an antidepressant effect from the buprenorphine. And it's not just that they're out of pain and they're out of withdrawal, they're getting their life back. For many of these people, it really is helpful for their mood. So going to be more and more interesting as this unfolds, but hopefully doctors will get the message and doctors will take appropriate action. Insurance companies will take appropriate action. Pharmacies will take appropriate action to make sure that those patients who need pain medication are able to access it, and if they need to come off of it, that doctors learn how to taper it gradually and to allow the pain receptors to reset, so that hopefully the patient will be in less pain on a lower dose, or at least the same level of pain on a lower dose. Most people with chronic pain do not get complete relief of their pain. It's just not realistic, and it doesn't happen.
And so there really is a piece for helping them with the acceptance of a certain level of pain, and helping them to learn to communicate about pain. But that's not the same as you get no pain relief.
And especially if you have the disease of addiction. That is a whole nother conversation for another day, pain management for someone who has the disease of addiction. But because you have the disease of addiction does not mean that you don't get pain relief. No, you need it, and there are ways to safely provided with minimal impact on the relapse potential, though there is some. So that's where it's got to be handled very carefully with communication with their addiction professionals to help them get through that period of time where they may need pain medication. And the medication-assisted recovery or medication-assisted treatment, buprenorphine and methadone are excellent pain relievers.
Well, and one thing I wanted to say real quickly is through this opioid crisis and now, you know, that it's being looked at much stronger, there's a lot more doctors now that have been given the ability to prescribe Suboxone.
Right.
But one of the bad things with that is that, like all things, we tend to overdo it in the beginning. So I'm getting calls from folks that, you know, maybe were on pain meds. They then transferred to a doctor who's now giving them Suboxone, but they have them at 25 to 30 milligrams a day, which that's quite a huge amount to have to taper off.
Right. Very, very difficult. It's a very difficult, and it's a lot, and many people are able to get by with a lot less because this really is very powerful.
Absolutely.
And there's a difference in what the amount that we use for someone who we might be detoxing, and the amount that somebody needs for treatment of pain. It's a significant difference. And sometimes people don't necessarily understand the difference, especially if they haven't been trained in addiction medicine and they don't know all the other things that need to go along with prescribing the buprenorphine for somebody.
And the patient, just as they've been taught their whole life, is, you know, whatever the doctor says. So if the doctor is telling them, you know, you need 24 milligrams of Suboxone a day, and, you know, when 8 could do just fine, they go along with that.
Right.
And then
but they wouldn't even have the information to question it. They would just be trusting the doctor because that's
what the doctor says. We're going to take another break. When we come back, we'll talk more about the opioid epidemic. Thanks for listening.
Perhaps you are struggling to cope with the disease of addiction. If not, you probably know a family member or friend that needs help in battling the cravings and the personal and professional damage done by the effects of drugs or alcohol. Get a pen and paper and be ready to write down the following. These are the issues that the trained staff at the Atlanta Healing Center address and treat every day. Their doctors and counselors with over 40 years of practice in the field of addiction can treat the suffering individual in a thoughtful, compassionate, and experienced manner and guide him or her along the path to recovery. So call 770-696-9862 and speak to a knowledgeable staff member about how you or your loved one can be helped to enjoy a better and healthier life. More information is also available on the website at www.atlantahealingcenter.com.
The disease of addiction is a life-altering challenge, not just for the person suffering its effects, but also for the family and friends who support and love the one caught in its grasp. What should be the course of treatment? Who is the best person to render treatment? And what is the best place to go for the care that is needed? We know that you want answers to these and many more questions. Call 770-696-9862 and speak to a representative of the Atlanta Healing Center. They can tailor a program specifically designed to address the needs of the person suffering with an addiction, or give you guidance as to where that help may be found. Information is the key, and the trained staff at AHC is here to assist. If you wish, you can also get more information on the website located at www.atlantahealingcenter.com.
This is Dr. Susan Blank, host of Detailing Addiction on America's Web Radio. Please join us at 4 p.m. on Tuesday afternoons.
You're listening to America's Web Radio on the AmericasBroadcastNetwork.com. Thank you for listening.
Welcome back. This is Detailing Addiction. I'm Dr. Susan Blank. This is America's Web Radio. And in studio, I have Michael Daly and David Donaldson from the Atlanta Healing Center. And we're giving everybody an update on the opioid epidemic. So there's another player besides the medicine cabinet, or heroin or fentanyl or the prescription opioids, that has been wreaking havoc for some time. And there's a very strong lobby that keeps preventing it becoming illegal, and that is this pesky substance called kratom.
Yes. It's everywhere basically right now. It's sort of like the CBD oil that you see.
Right.
And interestingly, it's illegal in its country of origin.
Correct.
It's not illegal here in the United States, and you see it advertised. You can be driving up the highway and you'll see billboards, kratom sold here. But where it's actually grown and harvested, it's an illegal product to have.
Correct. In Thailand. Southeast Asia. They are not fans of this. They have recognized for a long time the dangers of this particular substance. Now, it grows on a tree. It's a leaf, and the extract is sometimes in a powder form or in a tea or a liquid form. And if you were to just put in kratom into your search engine, and it's KRATOM, you'll find all sorts of testimonials and recommendations as this is the cure for the heroin epidemic. This is what you should do if you're trying to come off of prescription opioids, if you're having any kind of difficulty, or if you have pain, this is a great alternative pain medicine.
Mm-hmm.
And
it's also being pushed as a tea for people who have stress issues. If you just need some afternoon tea that's going to take your stress away.
Well, and it's even being infused into the energy drinks.
Right. For a very interesting combination.
And what we've seen at the Atlanta Healing Center for a long time is that it is instrumental in people relapsing back onto heroin.
Right.
People who've had some significant clean time will start using kratom because it's legal and because it's an energy drink
available.
Or because it's available. And before long, it's created such a habit that it's become too expensive, and they go back to heroin.
And there's a withdrawal, a
horrible
withdrawal.
As one of my patients told me one day, he said, it's a very terrible high. It is not even a good buzz, but it is a terrible withdrawal. And patients will report that they get to a point that they're having to use it every 2 hours, 24 hours a day. They are not able to sleep. They are not able to really do much of anything, and they're spending large amounts of money for this. Mm-hmm. So it seems easy. It does have some effect. So initially, like with most substances, it's attractive, it's available, and people get caught up in it. Mm-hmm. The bad news is that it is a very difficult withdrawal, and some studies have now shown that there have been 91 deaths related to kratom. So it's not just that it's addictive. It's not just that it has a bad withdrawal. It's not just that people are going back to using heroin. It's that in and of itself, 91 deaths, and another 61 fatal overdoses were found to have kratom in their system, although they think that other drugs may have been more responsible for the death.
Right. But they say that there's 7 actual deaths that kratom is the only
thing
drug responsible for that overdose.
And that's what's been particularly interesting for me to hear about, because we've known of a few overdoses over the past few years that the person was swearing what they used as kratom, and we kind of doubted that was the cause. We thought there must be something else in their system. because we'd never heard that kratom had that potential.
The other difficulty is that just like testing for fentanyl, kratom is a specific drug test. So it is not going to be picked up on a random drug test. I suspect that many coroners, many morgues that are doing autopsies may not have the full panel of potential drugs causing the overdose, and that they may not be testing for this.
Right.
Because it is a specific test and it doesn't give you an automatic opioid positive so that you're going to think, oh, I need to keep searching for something. So just like with the fentanyl, we may not know. We may not be able to detect it because it wasn't tested for, or in the case of fentanyl, they don't have the right test. They don't have the right reagent for this particular.
Right. So
I'm sorry. Part of what makes it attractive for the drug user is that that's something they can use when they know a test is coming.
Right.
Exactly.
That's not going to show up. But
if they're on probation, or if they're in drug court, or if their
mama's watching them,
right, it's not going to show up.
And it's not an inexpensive test, so it wouldn't necessarily, even in treatment centers, be one that would be routinely looked at. So it is a problem. The other side of it is that we've been able to get people off heroin and fentanyl and OxyContin and hydrocodone and all the other opioids. We've been able to get them off tramadol. We've been able to get them off a lot of them. This is one of those drugs that, like dextromethorphan,
I was just going to say, just like dextromethorphan,
over the counter, legal, and very difficult. The compulsion for people to go back and use is powerful. It's really powerful. I don't know whether it's because potentially it's available, they see it in the grocery store, they see it at the gas station, but patients tell me the cravings for this is really shockingly powerful, especially when they also can tell me it's a terrible high.
Right. And it's interesting because people, alcohol is readily available everywhere. People that have abused it and drink alcoholically, they're able to stop, even though it's in the grocery stores, it's in the restaurants, it's everywhere. But the kratom and the dextromethorphan, it's just crazy what a grip it gets on people.
Very difficult. And it's important for our listeners to know that both dextromethorphan and kratom, we have to use the same detox as we use for people with heroin. That is because of the strong effect on the central nervous system. We have to detox them using buprenorphine, just like we do someone who is on heroin. So this is not safe, it is not uncomplicated, and it's not without risk. And now that we've got this study coming out showing that there are confirmed deaths from it, and probably a lot more that we don't know about because of the difficulty testing for this particular substance, or for dextromethorphan, we're probably just looking at the tip of the iceberg. It is very concerning, and the fact that kids can get this, it's just very worrisome to me. And the more that it gets hyped on the internet as the solution for all of the problems for people, a lot of folks are getting sucked in that they're not necessarily looking for a high, but they're looking for something to relieve their pain. They don't want to ask their doctor, or they're looking for a way to come off the medications because their doctor says they can't take them anymore. So it's not just people looking to get high that are using this. And that's another worry because of the highly addictive nature of this.
Well, it's available at so many independent little gas station Quick Mart type things.
And I think that's part of why it's not taken seriously.
Every time a substance is sold at one of these little marts, it's generally something that sooner or later becomes banned, and sooner or later, or continuously it gets vamped to miss that testing.
Repackaged.
So it's like, okay, if you see something that's at one of these marts that's advertised as something great, it's probably going to be addictive, and you're going to end up regretting it.
That's a good wise words to think about, because this is baffling. It's baffling to the person that gets caught up in it. It's baffling to us that treat these folks, and it's baffling how this is still legal. Of course, tobacco is still legal. That is the biggest baffling thing that I can think of, how tobacco is still legal, but which you can also buy at convenience stores.
Yes.
Right beside the kratom.
Right beside the kratom. Just please be aware, and please, if you see kratom, or if you see your young person using cough syrup, dextromethorphan is the active ingredient that we're most worried about. If you see that in pill form, if you see that in liquid form, be extra concerned that there may be something else going on.
And generally, for the dextromethorphan, isn't it indicated on the packaging as DX or
DXM or DM?
Mm-hmm.
Exactly. So be real cautious with these over-the-counter remedies. Thank you all for listening. We hope that you have a very good week, and we will see you next week on Detailing Addiction.
You're listening to America's Web Radio on the AmericasBroadcastNetwork.com. Thank you for listening.
Perhaps you are struggling to cope with the disease of addiction. If not, you probably know a family member or friend that needs help in battling the cravings and the personal and professional damage done by the effects of drugs or alcohol. Get a pen and paper and be ready to write